Hi, I'm Dr. Dylan Whitaker, and in this abstract for EBPOM 2025 World Congress, I'll present how we use the electronic patient record data to rapidly evaluate and respond to the MHRA's public assessment report on modified release opioids. On the 12th of March in 2025, the MHRA published the report for acute postoperative pain. This was due to concerns around respiratory depression and long-term dependence. The report followed a 2022 and international consensus that long-acting opioids should not be routinely used for post-operative pain. Our aim was to use the routinely collected electronic data to identify modified release oxycodone and morphine prescriptions at 3 stages: prior to admission, during the post-operative period, and on discharge from hospital. Our secondary aim was to identify the variance between different surgical specialties and prescribers. This was a single-center retrospective study using the UCLH electronic patient record system. We reviewed over 129,000 adult elective surgeries from 2019 to 2025, excluding pediatric cases, those done under local anesthetic, and those not yet discharged. We identified modified release oxycodone and morphine prescriptions preoperatively, during the admission, and on discharge. We then cross-checked those during admission and on discharge to see whether they were a new prescription compared to their preoperative status. We found that across the study period, 8.8% of patients received a new modified release opioid after surgery, and 2.7% of patients were prescribed a modified release prescription on discharge. The prescribing peaked in 2021, and since then there has been a sustained reduction in inpatient and discharging prescribing. However, the data shows that there is continued use of modified release opioids, with 179 patients prescribed new modified release opioids post-op and 56 prescribed on discharge in 2025 up to the 14th of May. The highest prescribing rates were seen in thoracics, where 59% of patients have received modified release opioids during the study period. This was followed by orthopedics with 13% and neurosurgery with 11% of patients. In conclusion, by leveraging our digital infrastructure, we were able to complete data extraction, analysis, and reporting within 4 weeks of the MHRA alert. This system provided a clear baseline and is now being used for ongoing surveillance and targeted intervention. We're engaging with the high-use specialties to understand what drives practice and to develop electronic record-based interventions to help reduce inappropriate use. Thank you for your attention.